Finals SAQ54 Fascia Iliaca block. An 80-year-old woman is admitted to your hospital having sustained a proximal femoral fracture in a fall. A. How would you optimize this patient's pain preoperatively? First, assess pain immediately on admission, 30 minutes after analgesia given, hourly until settled on ward, and as part of routine observations thereafter. Analgesia to be given immediately on admission with suspected hip fracture, even if cognitively impaired. Pain control should be adequate to allow for investigations. Stepwise multimodal analgesia with paracetamol 6 hourly unless contraindicated. Opioids as necessary. Nerve block such as fascia iliaca block by trained personnel. NSAID not recommended. B. You decide to perform a fascia iliaca compartment block for analgesia. What are the borders of the fascia iliaca compartment, and which nerves are you attempting to block? Anterior border, posterior surface of fascia iliaca. Posterior border, anterior surface of iliacus and psoas major. Medially, origin of psoas major with vertebral column from which it originates to fuse with psoas fascia. Laterally, origin of iliacus muscle along the inner aspect of the iliac crest. Superiorly, the posterior lumbar fascia at its origin from the iliac crest. Inferiorly, fascia iliaca covers the iliacus as it passes behind the inguinal ligament, then fuses with fascia of muscles of the thigh, and thickening medially to the iliopectineal ligament. The nerves to be blocked includes the obturator nerve, femoral nerve, and lateral femoral cutaneous nerve of the thigh. This diagram shows the expected distribution of fascia iliaca sensory block. C. Describe how you would perform this block using an ultrasound-guided technique. Consent has already been obtained. You also have adequate assistance, emergency equipment, monitoring, and venous access. Patient in supine position. Full asepsis with hat, gown, gloves, mask, 0.5% chlorhexidine spray, air-dried, transducer sleeve, sterile ultrasound gel, 50 mm 22 gauge block needle, high-frequency linear array probe, positioned transversely just below inguinal ligament, lateral to femoral artery, identify fascia iliaca, fascia lata, and iliac psoas. Inject skin wheel of local anesthetic above where sartorius is visualized. In plain needle injection from lateral side, tip under fascia iliaca, ensure negative aspiration, inject 1 to 2 mL of local anesthetic, ensure fascia iliaca is seen lifting from the muscle, spreading laterally and medially towards femoral nerve. Continue to inject 30 to 40 mL of dilute local anesthetic, for example, 0.25% bupivacaine, ensuring maximum of 2 mg per kg not exceeded, with repeated negative aspiration. Chairman's report, 22.2% pass rate. In Part A, many candidates failed to mention assessment of pain as part of pre-op optimization. There was general lack of knowledge of anatomy in Part B. In Part C, some candidates failed to answer the question correctly and describe a technique using a nerve stimulator rather than ultrasound, or describe a femoral nerve block rather than fascia iliaca block. Some candidates wrote about assistance, emergency equipment, despite told in the question that this was unnecessary. Many of the answers were brief, but it was unclear whether it reflects a lack of knowledge or a lack of time. 2 recent exams have asked about pain management in patients with fractured hips, March 2012 and March 2014. Additional information. Fascia iliaca block. Indications includes anesthesia as sole technique for surgery on anterior or lateral thigh, and analgesia for hip and shaft of femur fractures, and surgery to the knee. Complications includes vascular puncture, nerve injury, local anesthetic systemic toxicity, intraperitoneal injection, and deep retroperitoneal abscesses. Advantages of fascia iliaca block. It reliably blocks the femoral nerve with minimal risk of inadvertent femoral artery, femoral vein or femoral nerve puncture, thereby increasing the safety and simplicity of the technique. Landmark approach does not use a peripheral nerve stimulator or ultrasound, as its safety relies on injection site well lateral to femoral artery. There is high associated blockade of lateral femoral cutaneous nerve than the perivascular approach. The suprainguinal approach more reliably blocks femoral, LFCN and obturator nerves than the infrainguinal approach. In a study by Chris Vermeulen et al., 80% of volunteers in the suprainguinal approach had complete sensory block of medial, anterior and lateral region of the thigh, compared with 30% for an inferior approach. Based on MRI scan, 8 out of 10 volunteers had LA spread to the obturator nerve for a suprainguinal approach, compared to 1 out of 10 volunteers in an infrainguinal approach. 40 mils of LA for suprainguinal approach more reliably spreads LA to the anatomical location of the 3 target nerves of the lumbar plexus than infrainguinal approach based on MRI. In a study by Kamya Bansal et al., concluded that suprainguinal fascia iliaca block had superior analgesic efficacy over infrainguinal approach in terms of reduced pain intensity, reduced 24-hour tramadol consumption, and better patient satisfaction. Infrainguinal fascia iliaca block landmark approach. Preparation as for ultrasound technique. Fine junction of middle and lateral thirds of inguinal ligament joining ASIS and pubic tubercle. Move 2 cm distal and 2 cm lateral. The aim is to be lateral to the neurovascular bundle. Needle needs to pass through the fascia lata, first pop, and fascia iliaca felt as the second pop. Use short bevel needles to aid detection of the pops when passing through fascial planes. Peripheral nerve stimulator not necessary. Injection point should always be 2 to 3 finger breaths lateral to the femoral artery. When injecting, if the subcutaneous tissue swell, this indicates that the needle placement is too superficial above the fascia iliaca. Withdraw needle and reposition. If it is difficult to inject, needle is probably too deep within the muscle of the iliacus. Withdraw needle and reposition. Suprainguinal fascia iliaca block. Preparation as for infrainguinal approach. Probe is placed over ASIS in parasagittal orientation. Slide probe inferior-medially along inguinal ligament towards pubic symphysis. After few centimeters, the anterior-inferior iliac spine should be seen as a peak hyperechoic shape. Overlying this is the iliacus muscle, with the internal oblique muscle superficial and cephalate, and the sartorius muscle superficial and caudate, together making a bow tie appearance. The fascia iliaca is the hyperechoic fascial layer covering the superficial surface of the iliacus. The deep circumflex iliac vessels are usually seen superficial to the fascia iliaca in the pelvis. Use color Doppler to identify these. Inject a skin wheel of local anesthetic above where the sartorius is visualized. Insert the needle from caudate end of the probe, aiming for local anesthetic spread under the fascia iliaca, deep to the deep circumflex iliac vessels in the cephalate direction. Correct pattern of spread is seen as the fascial plane being unzipped. Based on a study by Chris Vermeulen et al., CT scan and dissection findings suggested that the volume to reach the femoral nerve, obturator nerve and LFCN with the suprainguinal fascia iliaca block was 40 mils. Thank you.